Today is going to be over those structures as well as histology. So remember, we weren't looking at the microscope, but recognizing the trachea or pseudostratified columnar epithelium or the bronchioles or something. So today we're going to start the actual stages. We looked at the anatomy and the structures that the air would flow through. Today we're going to look at the first of the three phases of gas exchange, and that's just the movement of the air in and out of the lungs, what we call inspiration and expiration. Okay, and then on Thursday we'll look at gas exchange, and that's the binding of oxygen to hemoglobin and its solubility in the plasma, and the same thing for carbon dioxide. Friday we will look at control, so what drives breathing. And then Tuesday of next week is acid-base balance. Okay. There is an activity on acid-base balance that's an extra credit one, another 5 points. And there's some examples on how to do that and stuff that are on D2L. All right, so if you recall, we had two regions of the respiratory system. A whole series of structures were known as the conducting zone. And then we had the respiratory zone. So what were the structures, beginning and the end structures of the conducting zone? We start with the external nares and vestibule. And then we go to what level?
The nasal pharynx?
Well, not everything. I'm just saying beginning and end.
Oh, the pharynx.
The layer.
Not upper. I'm not looking at upper and lower respiratory tract. So larynx would be the end of the upper respiratory tract.
You're talking like the end.
We're talking about conducting zone, the last structure that air passes through before it has simple squamous epithelium.
Tertiary bronchi?
No, this bronchiole still have smooth muscle and simple cuboidal epithelia. So it's one of the bronchioles where we transition from conducting zone to respiratory zone.
Respiratory
bronchiole. The respiratory bronchiole would be the beginning of the respiratory zone.
The terminal bronchiole.
Yes.
The terminal is the end of respiratory.
So this would be the terminal bronchiole. It's the last bronchiolar structure that doesn't have any smooth simple squamous epithelium. The respiratory bronchiole still has bronchiolar tissue, simple cuboidal and smooth muscle, but it has regions. Remember the little blebs that look like grapes, where we have the alveolar air sacs blebbing off? And then finally we would extend this to the alveolus, or the air sac. All right, so these are the structures that we look at with pulmonary ventilation that move air in and out. So now, what is the force that's going to move air through these pathways into and out of the lungs?
Air pressure?
Air pressure. So we looked at blood flow as a difference in pressure. If we had a higher hydrostatic pressure and a lower hydrostatic pressure, the blood would flow from the high to the low hydrostatic pressure. For our airways, air flows from high air pressure to low air pressure. Right? So we have to be able to change the intrathoracic pressure. We can't change atmospheric pressure, not instantaneously anyway, and so we have to change intrathoracic pressure within the thoracic cavity. So let's look at the structures that do that. And this is a review of some of the anatomy. So muscles of inspiration. Inspiration is air flowing in. Airflow is from atmosphere or your external surroundings to the alveoli. Okay. So for that to happen, atmospheric pressure has to be higher than alveolar pressure. To do that, we have to change the pressure in the thoracic cavity. So how do we do that?
Changing volume.
Changing volume. Okay? Pressure, when we're talking about air pressure, has to do with the force of gas molecules bouncing off against the walls of the container and off each other. All right? So if you envision 100 molecules of nitrogen and oxygen mixed together, and we have a cubic foot, as we increase that cubic foot to 3 cubic feet, the same number of gas molecules are not as likely to bump into each other or to hit the side of the container. Therefore, the pressure drops. The same number of molecules are there, but they have more room to move around it. If we decrease that volume to half, then they're in closer quarters, they're more likely to bump into each other. All right? So that's why we use then the muscular structure of the thoracic cavity to change the volume of the intrathoracic space. So breathing in, inspiration, are 2 basic muscles, and you remember this from Bio 430, are the external intercostals and the diaphragm. So if you recall, the external intercostals are, and the internal intercostals for that matter, and I'm not going to distinguish between cartilage and ribs here. So external intercostals have their origin on the superior or the inferior rib. What do we call it?
Superior?
Superior. So inferior border, or the margin of the superior rib. They start posteriorly about 2 or 3 inches from the lateral to the vertebra, or actually they start at the vertebra and then stop about a couple of inches lateral from the sternum. And they're angled in this direction. Their insertion then would be the superior border of the inferior rib, because their purpose is to elevate. So their action is to lift or elevate the rib. So they're going to do this. So the angle is a V. You put the 2 left and right sides together, okay? And then they lift the ribs. So that's going to, you can notice that the ribs, except for the first rib, the ribs are at an angle. So when we lift the ribs, we increase the anterior-posterior diameter. Okay? This is just enough to drop the pressure a few millimeters of mercury. We're not making huge changes, but just enough to drop the pressure a little bit. Anybody remember the nerve, the innervation? It's not that difficult.
The external intercostal nerve.
Just intercostal nerve. Now, all you use were your intercostals to breathe, you would have rather shallow breathing. Okay? So, a muscle that creates a greater difference in intrathoracic pressure is the diaphragm. Remember, this is the dome-shaped muscle that goes up high under the ribs, so the top part of the diaphragm is probably about here. So that there's room for the liver and the stomach to fit up under the ribs. And you can see part of the diaphragm here. So there's a portion that's called a crus that has its origin on the lumbar vertebra. For the most part, the rest of the diaphragm has its origin from the lower ribs. What does it insert on? It's an hourglass shape of white connective tissue. Let's see if we have any of our model. called the central tendon. Remember, it's not a bone. So the central tendon. And action. So by elevating the ribs, this increases the anterior-posterior distance. And by lowering, flattens, and this increases the superior-inferior diameter. So both of these are enlarging the intrathoracic cavity. And the nerve?
The front?
This one you know.
Front?
Phrenic. Phrenic nerve, is that a cranial nerve or cervical or brachial plexus? Assuming you know it's not lumbar.
Cervical?
Cervical. Okay, C3, 4, and 5. Which is why if someone damages their spinal cord above C3, they need a ventilator. Because although our reflex for breathing, as we'll see on Friday, is instigated in the medulla, it has to pass out. These are from the spinal cord itself. All right, so these are muscles of inspiration, which is our normal breathing. Just open your mouth. Don't take a breath, just open your mouth. No air is moving, right? Because pressure in the alveoli is equal to pressure in the atmosphere. Now, if you want to push air out, you have to contract your abdomen, or push your abdominal muscles, push your diaphragm up, pull down your ribs. Now you can force air out. Okay? If you wanted to breathe air in, you would be using external intercostals and diaphragm to increase the diameter of your intrathoracic cavity. Now, there are times when we need accessory inspiration. Okay, you're running, you're hiking where there's a higher, or just living where there's a higher altitude that you're not acclimated yet. And so we use muscles that are not normal in everyday breathing, and these are called accessory muscles of inspiration. We've talked about pectoralis minor, serratus anterior, and sternocleidomastoid in Bio 430. Pectoralis minor is the one that is attached here from the ribs to the coracoid process and normally protracts the scapula. Serratus anterior comes from the back of the scapula, from the ribs to the back of the scapula, and pulls the scapula up against, tight against the ribs. And sternocleidomastoid normally functions to turn the head or flex it. But for all of these, if we stabilize the scapula or stabilize the head, then we can move the sternum or we can move the ribs. Okay, so we have to flip attachments. Scalenes we haven't talked about, at least in Bio 430 in my class. All right. Scalenes are a set of 3 muscles located right here that come from cervical vertebra and insert either onto the sternum or onto the first rib. Our brachial plexus actually passes through them. So these are all muscles that you would use when you needed to take a deeper breath than normal. Okay, down at the bottom, it says muscles of active expiration. So why do we add the word active?
Like when you're forcing air out.
All right, because normal expiration, normal breathing out, is merely a relaxation of the diaphragm and the external intercostals. Okay, so you take a deep breath, and then you just sigh, and you're not contracting any muscles. All right, so in our normal expiration, we're merely allowing these muscles to move, the ribs to move down, and the diaphragm to rise up, and that shrinks our intrathoracic cavity, and pressure increases. But if you were trying to force air out, if you were trying to blow into a balloon, okay, or if you just open your mouth and now force air out, you can feel your abdominal muscles tighten. All right, then we use these muscles. So the internal intercostals are going to have the reverse origin. So the superior border of the inferior rib and insert on the inferior border of the superior rib. Your action is to depress the ribs, and nerves are still the same, intercostals. So their appearance is going to be at right angles. They have this appearance. You can visualize them best just lateral to the sternum, because the external intercostals stop short of the sternum. So here are the external intercostals here, and these are the internal intercostals. Remember, the serratus anterior is going to actually be attached to the ribs themselves, whereas the intercostals are going to be in between. And the abdominals are the obliques and the rectus abdominis. I'm not going to go through all of their origins and insertions. We have a couple of lung models here. So in this case, the plastic dome is representing the rib cage, and it's rigid, it's not moving. So we're not looking at the function of the intercostal muscles. And the diaphragm is representing by this rubber membrane. Right? So by lowering this, it's representing contraction of the diaphragm, and then when I push it back up, it would be relaxation. And then obviously the two balloons are your lungs, with the bronchi and trachea represented. So the only open airspace is this opening here in the rubber stopper. So you can see the lungs are collapsed. And now if I pull on this, you can see the increased air is being pushed, not pulled, air is being pushed into the lungs. The reason being is because by pulling down on the rubber diaphragm, representing the actual muscular diaphragm, all right, I'm increasing the volume of this chamber. Pressure around the rubber balloons drops. Atmospheric pressure now is higher than pressure that's in this dome, and air is pushed into the balloons. Now when I push up on this, I'm decreasing the volume within this plastic dome. Pressure around the balloons is higher than atmospheric pressure, what's around here, outside here, and air is being pushed out of the balloons, right? So the airflow, again, is a matter of high pressure to low pressure. You're not sucking air in, we talk about that, but it's really pressure being pushing the air into your lungs and pressure pushing the air out of the lungs, okay? Which will lead us to a better understanding of some of the problems with breathing, such as asthma. When you're trying to, is it easier to breathe in or breathe out? Those of you that, or anybody that knows anything about asthma.
It's out.
Breathing in. Easier? It's easier. All right, or any form of COPD. So imagine what's happening to pressure within the thoracic cavity when you breathe in. I'm lowering my diaphragm. I'm elevating my ribs. I'm increasing the volume and decreasing pressure. So atmospheric air is pushing through those narrow tubes. With asthma, the bronchioles become smaller as the smooth muscle constricts. The diameter is also smaller because there's an inflammatory response and increased mucus and fluid lining that cavity. So the volume itself, the space is decreased and then it's constricted. So when I lower the diaphragm and raise my ribs, I'm decreasing pressure, and that makes it easier for atmospheric pressure to push air in. Now when I breathe out, I'm decreasing pressure, all right? Those airways are narrowed, and so it takes a long time, or it's more difficult for air to go out. So what do? I push more. I try to increase intrathoracic pressure greater to push the air out of my lungs. Not only am I pushing air out of my lungs, but I'm squeezing the lungs, right? So the more you push, the greater the collapsing force is on those airways. And so breathing in is a negative, things are expanding. Breathing out is a increasing of pressure. So while you're trying to push air through tiny little airways, that same pressure that you're using to push the air through is also collapsing those little airways. Okay? So that's why you see individuals with emphysema that have these big barrel chests from muscular development. They try to push air out. So this is just going through the different movements of the rib lifting up, and it's just slightly, we're really only changing pressures a few millimeters. This reminds me. We'll come back to that in a moment. So that's the extra credit opportunity. A couple points. All right, so here's an image of what I was talking about with air pressure. Okay, we need to spend a little bit of time talking about pressures. So here we have, I'm talking about a cubic foot of space with the air bouncing around. We increase that space fewer times that the gas molecules are bouncing into each other, so pressure drops. Decrease the space, more opportunity for the gas molecules to bump into each other. So there's an inverse relationship between volume and air pressure. Okay. And that's considered to be Boyle's law. So we don't have to change the number of gas molecules, we change the volume. What else would change the pressure?
Temperature.
Temperature, okay? Even though we don't change the number of volumes, we're changing the amount of energy with which they move around and increasing the force and the rate, probability with which they would bump into each other. May I erase the board? We're on page 40 now. So you can see in this graph here, as volume decreases, pressure is increasing. Okay. So that's what we mean by an inverse relationship. So we hadn't yet talked about the pleura on Thursday. I said we would get to it, so this is where I want to bring that in, because we need the pleura for several different components, part of which is helping to expand the lungs. So at the hilus or hilum of the lung is where we have the bronchi and pulmonary veins and arteries entering and leaving. So we're just going to draw that as one block of structure. So that represents everything that's coming into and leaving the lung. Then we have our visceral pleura. And you're familiar with this by now. It's a simple squamous epithelium attached to the surface of the lungs by loose, irregular connective tissue. And then we have the parietal pleura, which is attached to the body wall and to the diaphragm. So you'll notice that there is a higher, a greater gap inferiorly. These spaces are known as the pleural recesses, and this is greater posteriorly because the diaphragm is shaped from lateral. So this would be the diaphragm with the liver here. So in the back, there's a greater space for the lungs to expand posteriorly. And then, of course, we have pleural cavity with serous fluid. between the two. So this is what I drew here, laterally. So during inspiration, we increase the volume of the intrathoracic cavity, and pressure drops. So intrathoracic volume increases, alveolar volume increases, pressure drops, and atmospheric pressure pushes in. Right? Then the diaphragm is raised, the ribs move down, and the reverse occurs. So when you opened, well, let me come back to the series of pressures. So we're going to have atmospheric pressure. And at sea level, that is given as 760 millimeters of mercury. Okay. Some of you may be used to the word torr, T-O-R-R, another way of measuring pressures, but most of the respiratory components are done in millimeters of mercury unless you're in some of the armed forces. Now we only need a few millimeters difference for air to move in and out. All right? So the other pressures we're going to look at are intraalveolar. Will that be below or above atmospheric pressure?
Doesn't vary?
Trick question.
Same.
It's going to vary. It could be the same, it could be more, it could be less, depending on what stage of breathing you are. So if I just open my mouth, as I've had you do already, it's equal. Okay? If I am breathing in, it has to be lower because atmospheric pressure is pushing air into my lungs. If I am breathing out, it has to be greater. Okay? And then we have intrapleural pressure. So this can be equal to, greater than, or less than atmospheric pressure. Intrapleural pressure will always be less than intraalveolar and atmospheric, as long as the integrity of the pleural cavity is intact. Obviously, if we have a chest wound or something like that, that integrity is not present. So here's a diagram. I've only drawn one lung up on the board, all right? But here's a diagram. So atmospheric pressure is what pushes the air into, or what we push out against. Intrapleural pressure is usually about 4 millimeters less than intraalveolar pressure. So you see, we're not changing that very much. It's just a few millimeters that will change it. Now, what do we mean? Let's just go back and revisit a little bit, not revisit, but kind of explain graphically what we mean by intra or atmospheric pressure. I don't know if I have an image on here or not. So, if we are at sea level, and obviously this will change, and we take a flat tray of mercury, and we place a vacuum tube in that flat tray. We set it on the sand. I'll make the mercury green here. It actually isn't, but anyway. Then, so there's no air in my vacuum tube. We measure it up the side here. There are gas molecules in the air, right? I mean, if you don't, all you have to do is take your hand and just go like this, and you can feel the resistance. Okay? If I were out in space doing that, I wouldn't be able to create a wind. So these gas molecules, mostly nitrogen, and some oxygen, are being pulled down towards this flat surface. What's pulling them down?
Gravity.
Gravity, okay? And they have a mass. they have to do is take the molecular weight, all right? And they have a mass that's pushing down on that surface of the mercury. So the more molecules I have, or the greater the force of gravity that's pushing down, that pressure that's exerted by these molecules pushing down on it is going to cause my mercury to rise up in this vacuum tube. And at sea level, it will rise up to 760 millimeters. Now, if I take this apparatus to Death Valley, where I'm about 23 feet below sea level, almost 1 atmosphere, is that mercury level going to be higher or lower?
It's going to be higher.
Higher, okay? If I take it up to one of the 14 Niner peaks, Mount McKinley or whatever, what would happen to it?
Lower.
It'll be lower because there's fewer molecules of gas that are going to be pulled down onto the surface. Okay? So that's beginning of the year, my daughter had to do a presentation. It was an anatomy class, but she had to do a physiology presentation on some topic that she could pick. And she had to read a book about it and do a PowerPoint presentation with visual aids. And I looked at the various topics, and the only topic that I had a book on at home was high altitude sickness. It had nothing to do with anatomy, but I had the book Into Thin Air by John Krakauer. And so we scoured the stores, and she made, with my help, she made a manometer, a pressure thing. And so we got a pie plate and agar, just gelatin without the sugar, so not Jello, but you know my favorite biological material. And we added food coloring to it, and then I was looking for some kind of tube, and I found a big, wide plastic cylinder that bubble solutions were sold in. And so we filled it about 2/3 of the way with the Jello, let it harden, and then turned it upside down and warmed it just enough to let it slip down to the bottom. And because it had this wide screw opening, we screwed it into the pie plate. So she had this pie plate with yellow gelatin and then this 1.5-inch wide tube coming up. It looked just like that. So that was her description of a manometer. And then she created she had a poster board, and she was showing how there was less gas molecules. And so, and this part was her idea, not mine. She got bubble wrap, and we had an elevation showing different heights of mountains. And so she said, so as you move up in altitude, you start losing gas molecules, and she popped the bubbles. So she, at this height, you have 1 out of 3, and so she'd pop 1 out of every 3 bubbles, and you get it to this height, you have, you've lost 2 out of 3. And so she was illustrating the effect that we'll see, I'll talk about on Friday, with effects of altitude on the amount of oxygen available. So if you can understand atmospheric pressure, this is essential for understanding Thursday's lecture when we talk about oxygen tension, all right? When we talk about the amount of oxygen and carbon dioxide dissolved in our blood. So think about pressure. If it's easier for you to think of, instead of millimeters of mercury, once we understand this, as we breathe air in, think of, you can change these numbers to just actual molecules. So we have 104 millimeters of mercury of oxygen in our alveoli. That's the pressure that they exert on the alveolar wall. It's not exactly the same, but it can, if you want to think of it as 100 molecules of oxygen bouncing around, okay, that might ease the transition to visualizing this actual process as we compare pressure. All right, so as we lower the diaphragm and lift the ribs, we're not changing atmospheric pressure, right? That's going to stay the same. But what we are changing is the intrathoracic pressure. So that's going to drop. Our intraalveolar pressure is going to drop. And atmospheric pressure now will push air into the lungs. At the same time, intrapleural pressure will drop. But notice over there, I said it's always less than alveolar pressure. Okay? That lower pressure, along with surface tension, helps to keep the lungs expanded. Remember we talked about surfactant on Thursday? And surfactant was surface tension between the water molecules lining the alveoli. And surfactant helped to eliminate the charges because of its lipid nature. And so we didn't want surface tension in the alveoli. We didn't want the alveoli to be collapsed. However, surface tension, an attraction between the water molecules of the visceral and the parietal pleura, is a helpful surface tension. Because as we move the thoracic wall out, it pulls the lung tissue with it. All right, so that helps to expand the lungs along with just the negative pressure that's present there as well. So here you can see at rest, the intrapleural pressure would be about 756. However, intraalveolar pressure is equal to atmospheric pressure. Then when you're inhaling, intraalveolar pressure drops. Intrapleural pressure would also drop because it's always less than intraalveolar. So atmospheric pressure pushes air into the lungs. And then when you're exhaling, both of these would rise. Intraalveolar pressure is never greater than atmospheric pressure, but intraalveolar pressure would be. So you have a diagram of lines on page 42. And I'll show you a slide in a moment that matches that. But here we have the difference between outside and inside. All right, so the 0 is when both intraalveolar and atmospheric pressures are equal. If we're at sea level, that number would be 760. Okay? So when intrapulmonary or intraalveolar pressure is greater, is inspiration or expiration occurring here? Expiration. All right? And when it's lower, inspiration is occurring. Because atmospheric pressure is pushing air into the lungs, alveolar pressure is pushing air out of the lungs. Right? This bottom line here is showing the intrapulmonary pressure. So it's always less than intraalveolar, but never greater than atmospheric. Right. So going up, coming back down again, these numbers can be 762, 758, just depends on how deep a breath that you draw. All right, so when we are above, expiration. When we're below, inspiration. Remember, it's just like blood flow. It's from high pressure to low pressure. Now, what happens if we have damage to that thoracic wall? All right? And let's say that it is internal damage. I have a former student who works here at the college whose daughter, she was a student of mine back in like 98, 99, and her daughter, a 3-year-old daughter, would just have a spontaneous rupture and tearing of the visceral pleura and the little alveolar sacs out near the edge of the lung. So just internally, all right? So now when she breathes, and she lowers her atmospheric pressure, and air is pushed into her lungs to fill the alveoli. And this is negative normally, but when she's breathing in, what's happening? Air is going to go out that space into the pleural cavity. Okay. And now when she breathes out, the arrows should be reversed, but some of that air is going to get trapped in there.
What was it called that she had?
She had a spontaneous pneumothorax. So now, every time she breathes, a little bit more air is going to end up in that pleural cavity. Okay? What's going to happen to, a little bit like cardiac tamponade, but not as rapid. So what's going to happen now to the volume of her lungs?
Decrease.
It's going to get smaller and smaller as more and more air ends up in the pleural cavity. Because now when she expands, it's not going to have the room to expand. All right, so that's one way of getting a pneumothorax. Another is to have a broken rib, all right, and have air coming in from the outside. So let's follow through with that. So as you, let's say that a broken rib has torn the outside of the parietal pleura, and may or may not have torn the visceral pleura. Now when you breathe in, you're increasing the volume, you're decreasing the pressure. So not only is atmospheric pressure going to come in, push air in through the bronchi, it's going to push air in through this opening in the parietal pleura. Okay? And the same event will happen. The pleural cavity will fill up with air, and the lung size gets smaller and smaller. This is especially dangerous when it happens on the left lung. Well, it can happen on both. It's called a tension pneumothorax, and it can shift the heart to one side and make it difficult for the heart to pump as the thoracic cavity fills up with air. Now, it could fill up with fluid if it was, you know, a very bleeding damage. So let me see if I can pull this up here on.
So is a pneumothorax just a hole in either the visceral or the parietal?
It's something that allows air into the pleural cavity.
The lungs are encased by 2 layers of tissue, similar to a fist that has been pushed into a balloon. The space between the layers, called the pleural cavity, is lubricated so that the lungs can slide comfortably across the chest wall. If air enters the space, it is referred to as a pneumothorax. One type of pneumothorax, called a traumatic pneumothorax, can be caused by injury to the chest. A blunt or penetrating chest injury can cause a small tear on the surface of the lung, allowing air to enter the pleural cavity and to become trapped. The pocket of air produces excessive pressure on the lung, causing it to collapse. A spontaneous pneumothorax occurs without injury as a result of certain lung diseases, such as asthma, emphysema, or COPD. Small air-filled sacs called blebs can form on the lungs. If the blebs rupture, they can release air into the pleural cavity. Pressure from the trapped air causes the lung to collapse. However, a spontaneous pneumothorax can also develop in a person with no obvious risk factors or disease. This condition is more common in smokers and in men between the ages of 20 and 40. A tension pneumothorax is a serious complication that can develop with any pneumothorax. If the pocket of trapped air cannot escape and continues to grow, the increased pressure in the pleural cavity can push the heart and major blood vessels to the other side of the chest. When this shift takes place, it causes a significant drop in blood pressure. This is a life-threatening condition that requires immediate medical attention.
And there's a couple others. I don't know why I have to do this, I just do that first part. Quick.
During normal respiration, the lungs expand and contract within the chest cavity. The lungs are encased by 2 layers of tissue, similar to a fist that has been pushed into a balloon. The space between the layers, called the pleural cavity, is lubricated so that the lungs can slide comfortably across the chest wall. If air enters the space, it is referred to as a pneumothorax.
I'll look for it during lab. But this is the creation of a pneumothorax.
Oh, wow. That's beautiful.
I don't think I want to see artificial insemination. Oh, well, I'll see if I can find it in the lab.
Why don't you just copy it?
There we go.
Zaprezentujemy, jak pracują zdrowe płuca, cały proces
This is what we're not going to do pneumothorax, but we're going to be
tkania
working
zdrowa,
with the sheep.
nieuszkodzona. Jak to wygląda w sytuacji, kiedy mamy szczelnie
Right, so the plastic bag,
w klatce piersiowej. Okej, drugi preparat został przez nas uszkodzony. Jak to zaprezentujemy?
you read up at the top, the lungs are injured, air leaks into the pleural cavity, which is the space between the lungs. So that shiny surface on the lung is the visceral flora, and the bag is representing the parietal flora.
Pay attention.
Every time they pump air into the sheep lung, some of that's escaping out to the pleural cavity.
Teraz po natchnięciu, opatrzenie.
Alright? I'll post those up on a few years ago, quite a few years ago, I read an article, well actually it was a news item, and I've tried to find it again and haven't been able to. I did find a printed article about a woman who had gone to Singapore on vacation, just a single British girl on her own. While she was over there, she met a guy, and they spent time with each other for the 2 weeks. And it came time for her to leave, and so he took her to the airport on his motorcycle. So I thought it had much luggage, but then I guess all you need in the tropics is a bikini and a towel. But on the way, they were in an accident, and she got banged up, but she needed to get back to work, so they continued on to the airport, and the attendants were like, "Are you sure you really want to get on this plane?" And she was like, "Yeah, I need to get to go." And so they took off, and she bent over to get something out of her bag on the floor, and she had a broken rib, didn't realize it, and it punctured her lung. And she started to develop a tension pneumothorax. You can live with one lung. Okay, my father-in-law had one lung and one lobe of the other lung and was fine. So the emergency is the tension pneumothorax, where there is the shifting and compression with that increased pressure. He didn't lead into it, but with the increased intrathoracic pressure from the pneumothorax, the heart can't expand. Remember we talked about the effect of the Valsalva maneuver, and that's kind of, the heart is under pressure too, and therefore blood can't move into the heart as much. And so a call went out for doctors on board. They were kind of at that halfway point where they didn't have time to go. They couldn't turn around, and they were kind of stuck in the middle. And so they proceeded. I'm not quite sure of how they did it. Typically a chest tube is used to allow air to be removed from a pneumothorax. They'll do an incision into the pleural cavity, usually around the 9th rib. You don't want to go too high or you're going to have damage of cutting into the lung itself. You go too low, you're below the diaphragm. and you can puncture the liver or the spleen depending on what side you're at. So you want to go kind of in between those danger zones. And the chest tube is inserted that goes up to a bottle that has a valve usually, so that the air rises above the water and doesn't come back into the chest when the person breathes in. So they made up this makeshift chest tube. I think I have some diagrams here of chest tubes. Yeah, so here they have a chest tube in, and this is draining fluid, but you can use a couple of bottle methods so that one doesn't go in the other. But with the chest tube for air, it's usually up higher because the air will rise. And so they did this. They always ask for shoestrings when they do emergency stuff like that, whether it's delivering a baby or whatever. A coat hanger, which is what they use to poke the hole in her chest wall. A couple of water bottles, and you can put, I don't know what they use for tubing, but they put it up above the level of the water, because obviously if they put it in, the water would have drained down. But anyway, they were able to create this makeshift chest tube situation and draw enough air out of her lungs that the tension pneumothorax part at least was alleviated. So I thought, oh, you know, she went back, and one was an OBGYN doctor, the other was a family practice physician. So the romantic thing would have her to have gone back and married one of the doctors, but she didn't. She went back to Singapore and got together with the guy that caused the whole thing. But it was just, you know, until I had read about the tension part of it, it was like, well, so losing part of your lung isn't that big a deal. But it is when it affects the expansion of the heart.
So
if we go back to the x-ray here, all right, you can see how, on this case, the lung is, this side of the lung is collapsed. The whole pleural cavity in space is smaller and pushing up, and the lung is shifting the heart over to the opposite side. Again, pressure. Okay, yes?
So that one with the tube, that would only really work if she had a lot of blood flowing into her.
Right. Because they would have to stop the bleeding. Because well, they could withdraw blood, but if it was that much blood, then she was at risk for blood loss as well.
But if it was just filling with air?
Pardon?
But what
it was just filling up with air. The air can also create the pneumothorax, the tension pneumothorax.
Yeah, so really one of the things the video has said, when the air gets trapped in the pleural cavity, that's what, that increase in pressure is what causes the lung to collapse? Okay. Make sure I understood that.
So back to this description here. An additional, I think it's not much, I think it's additional 2 points. If you send me a picture, or show me a picture of, this is the emergency, someone, let's say, is in an automobile accident and they've been extracted from the vehicle, and you see that every time they breathe, their chest bubbles. It'll probably be a bloody froth, but every time they breathe, it bubble with bloody froth kind of comes out of that. It's an indication that the pleural cavity has been compromised, and so air is bubbling out of that space. And so the emergency treatment for that is to block that space. What you want to do, you don't want to tape it over completely, but you want to lift one corner, leave one corner untaped, so you would put a piece of plastic wrap, saran wrap, something like that. You don't want to just completely wrap them around and seal it off, but you want to leave one corner free, so you tape down 3 sides. Then when they breathe out, the increased pressure is going to push air out of that pleural cavity. And when they breathe in, the sucking pressure will suck the plastic up against the skin so they can't pull more air back in again. So what happens when it's damaged on both sides like this is when you breathe air in, if it's an external wound damage, when you breathe air in, air is going to be pulled in through that wound into the pleural cavity. When you breathe air out, air is going to be pushed out of the lungs into the pleural cavity. So no matter whether you're breathing in or breathing out, you're increasing the volume of the pleural cavity. So by putting plastic over that and leaving one corner free, it allows air to be pushed out from the pleural cavity, and then instead of pulling air back in again, it comes back and seals due to the negative pressure. Okay? So just send me an image or show me a picture that you have plastic wrap and tape, adhesive tape, bandage tape kind of thing, in your car or in your vehicle or whatever, and that's 2 points. Okay, again, no one's ever written and said, hey, I got a chance to use it, but just in case. All right, let's stop here and take a break. And when we come back, we'll start at page 44. And we're going to go through till page 52. So about another 40 minutes when we get back, and then we'll have that time. So it's about a 12 till 20 up. Yeah, we'll have last night. You guys haven't really had official. So we did that.
Surface area.
Surfing the radius. Yeah, so we had the radius of the blood vessel,
The viscosity?
the length, and viscosity. All right? So when we look at factors that affect the peripheral resistance for blood flow, we had the radius of the vessel, we had viscosity of blood, and we had the length of the blood vessel. So these similar factors can affect resistance for airflow. Which do you think is the most important?
The radius?
The radius. All right. So the radius of the airway. And for our blood flow, we mentioned this on Thursday, or I mentioned on Thursday, the most important blood vessel was is the the arterial, and the most important airway for resistance is the bronchial. All right, the bronchial, if you recall, is the first structure that lacks cartilage. So the bronchi are not going to be able to change their diameter to much significant degree because of the cartilage. And if we go past the bronchial into the alveolar ducts, we lose our smooth muscle. Okay? So it lacks cartilage, but it still has smooth muscle for constriction and dilation. For our autonomic nervous system, parasympathetic system is going to result in constriction of the airway. And sympathetic is going to result in dilation. Which makes sense when you think of the fact that if you have to flee or fight, you need a more dilated airway. And in this case, we're talking about beta-2 receptors. Now, certainly if air gets thick, all right, if there's a lot of pollutants in the air, if there's a lot of humidity, it can make it difficult to move air into and out of the lungs, but that usually is not as much of a factor. And then length. This is typically only in an emergency situation. In other words, we can decrease and increase the number of our blood vessels by losing weight or gaining weight. All right, so if we gain weight, we have more blood vessels supplying our adipose tissue. It's going to increase surface area and resistance. We don't really, unless we have a section of the lung removed, it's a little difficult to add or change the length. But you can do so if someone's on an artificial ventilator, the long tubing that is added that they have to breathe through. And obviously if they're on a ventilator though, they're having force added, they're not having to draw air through that long piece of tubing. But any of you that have gone snorkeling, all right, and you're trying to breathe through a snorkel tube, that's adding length to the distance that you have to move air. And so that's going to increase or affect resistance. So airway resistance. Lung compliance. The difference between compliance and elasticity. Well, maybe in China, smog pollution would have a bit of an effect there. Lung compliance. on elasticity are related, but are not exactly the same. Let's say, so I have an elastic band here, right? And let's say that over here I have a hair band. It's still elastic, but which one's going to require greater force for me to stretch out with my fingers? The hair band, okay? So compliance is the ease of stretchability. So a lung that has low compliance is not going to be able to expand very easily. It's going to be stiff, in other words. And a lung that has high compliance is going to be very easily expandable. All right? So you'll notice down here on our chart of compliance, an individual with pulmonary fibrosis is going to have low compliance. They have a lot of additional collagen fibers and connective tissue built up around their alveoli. Collagen fibers aren't stretchy, okay? So they have low compliance. It requires a greater force. So this is the distending pressure down here on the x-axis. It requires a greater force for less volume of expansion. Now emphysema. We have a case study on emphysema coming up. And emphysema is a problem with loss of alveoli. So if you imagine a typical lung has, say within a volume, any given volume, 10 of those small alveolar sacs. With emphysema, those walls between the individual alveolar sacs break down. So instead of having 10, we may have 3 or 4 large ones. So there's less surface area for gas exchange, but it's already kind of a large room. So it's without all the individual little walls, they puff up a little bit easier. All right? There's a problem because of the surface area and gas exchange. We're not getting as much gas exchange across the blood vessel, but there's not as much, instead of blowing up, 100 little balloons, we're only blowing up one large one, and the walls are easily expandable. So emphysema is going to have high compliance and fibrosis low compliance. Right? So that's the stretchiness. Now, elasticity refers to the recoil. Once it's expanded, does it come back to its normal size? Okay. So the ability of the lung to recoil it. So surface tension is going to affect both compliance and elasticity. So if we have surfactant, we lower the surface tension. So it makes it easier to inflate, all right, and it recoils after it's inflated better. So the ease with which it stretches out is compliance, the ease with which it returns is elasticity. So emphysema has high compliance but low elasticity. Once it's stretched out there, it doesn't come back to its normal volume very easily. All right, so with small alveoli, so as we stretch an alveolus, we take one of those air sacs and we stretch it, the surface tension increases because we're losing coverage by the surfactant. All right, because the same amount of surfactant is present, and so we're losing some of that coverage. So that as we exhale, then we gain more of that surfactant, and surface tension goes down. So again, surface tension is something we don't want to have in our alveoli, and it's something we do want to have in the pleural cavity because it keeps the visceral and parietal pleura attached to each other, and as the lungs move out, it helps to expand the lungs. Whereas if we have it, we don't want surface tension within the alveoli itself because that's going to tend to collapse the lungs.
Is the surface tension in the pleural cavity Does that increase the elasticity or?
It doesn't increase the elasticity so much as it aids the negative pressure in keeping the lungs expanded. So it kind of, it's like a force. It keeps the surface of the lungs stuck to the parietal pleura. So when you breathe out, it kind of pulls. It's an aiding force. So the lower pressure in the intrapleural cavity is helping to expand the lungs. The surface tension aids that. It kind of counteracts the normal elasticity of the lungs wanting to keep recoiled. And it helps to keep the lungs from just staying recoiled. It helps their expansion. All right, so I'm not sure what that's doing there. I just used some, okay. Seeing that there's some information I wanted that in there so I wouldn't lose it. So now we're going to finish up by looking at pulmonary volumes. So I'm on page 46. We're going to do these tests on Thursday. So you might want to start swimming between now and Thursday so that you have good values. Well, people that swim have, or if you have someone who's been in surgery, they have those little, they come home with those, I don't know what they call them, breathing exercises to create resistance. You probably won't change much between now and Thursday, but. So we have something that looks like this that we'll use on Thursday. We're also going to use the computers to do some of, in fact we may use the computers instead of that because it'll be a little bit more accurate. Some programs that have called BioPack that we'll utilize. So let's look at what these volumes are. So first of all, we're going to talk about tidal volume. All right? You're going to breathe in and you breathe out. And you breathe in and you breathe out. You breathe in and you breathe out. Typically, you breathe in for about 2 seconds and breathe out for 3. Okay? But the volume should be the same. Just like the volume that comes into the heart should be the same as the volume that goes out of the heart so we don't start backing things up. Now this is one of the most variable of our measurements because it's something you can think about. So when you're trying to measure this and you're actually thinking about I'm breathing, you could be the normal volume for tidal volume is approximately 500 mils. That's either in or 500 mils out. It's not the sum of the two. Okay? Once you start to think about it, you might breathe in 1,000 mils very easily. Or you might only breathe in 100 because you're thinking about it. So that's going to affect some of the other measurements. All right? So that's tidal volume. And now take in a normal breath, what you think is a normal breath. Now take it as deep a breath as you can on top of that. Okay, lower your diaphragm. That difference, so we breathe in our normal amount. And then the amount that you can breathe in above that, that difference is known as inspiratory reserve volume. And obviously, this provides you with the increased amount of air that you might need for extra activities, exertion, whatever. So inspiratory reserve volume is variable depending on your height, well the whole thing, vital capacity and all that, depending on your height or depending on your gender, but in a range of 2,000 to 3,000 mils. Not 2 mils, 2,000 to 3,000. Some of us have less. So again, as you age, this number gets less. All right? Now, breathe out. And then breathe out everything. And this difference is called expiratory reserve volume. take a deep breath. We're up here. Just relax. We're here. Now force it out. And that's the difference to here. Okay? So that's the expiratory reserve. It's a little bit less. It's usually about approximately half of the inspiratory reserve. So 1,000 to 1,500. Now if we add all those up, inspiratory reserve plus tidal volume plus expiratory reserve, that entire volume is known as vital capacity. Interestingly enough, every textbook I've ever taught out of for the last 30 years has given vital capacity as equal to 4,800 mils, 4.8 liters. And yet it varies by gender, and it varies by race and by height. There's a formula that you can use to figure out your own, but it's also on this chart. So this is the predicted vital capacity for women age 16. The highest volume is at the youngest, so age 16 to, anybody have a calculator? You take 194 and divide by 2.54.
94 divided by 2.54.
It's the height.
You said
2.54.
194 divided by?
2.54.
76.3.
Yeah.
Okay, so 76 inches.
Oh, 36.
72 would be 6 feet.
Okay.
So a 16-year-old who's 6'4",
Dang.
okay, has the, so that's here, and that's the youngest is up here, oldest is down here, tallest is up here. So the youngest, tallest individual as a female is 3,900 is her predicted vital capacity.
Oh, wow.
That's the highest value. If you're 74 and 6'4",
Wow.
you don't have osteoporosis and start slumping, it's about 2,800, so it drops by about 1,000. Okay, so females are 1,000 less. Predict average is 4,800. All right. So for males, if you're 16 and 6'4", your predicted value is 5,000. However, what's 186 divided by 2.54?
73.
73. So 6'1". All right. So this little corner up here in males are the only ones that have a predicted value of 4,800. All the rest of these males and none of the females have a predicted value of 4.8 liters. So I think this came from a group of 20-year-old, 18-year-old males that were in the Coast Guard and had to swim every day, because you see this in a chart and it's like it's not reasonable. Using the wet spirometer, though I think we'll do most of ours on the computer. What this does, and I had whooping cough pertussis when I was 5, so that's my excuse. I used to get to 32. I don't think I'm even going to, I haven't been running in a while. So this only measures by blowing out, all right? So we'll see if I even get to 1,000 this time. Stand up tall, straight, you're not all hunched over. And you try to take in as great amount of air as you can. And we're going to do this, if we do this, we'll still do it even on the computer. Raising my heels off the ground doesn't help, but it makes me think like I'm breathing in more. 1400. How's the core showing?
Oh. Better than nothing.
Well, true, very true. Must have leaked out somewhere. You can get to 28. Well, I made it to 1600 that time.
Hey.
So anyway, so that's all right, so those are pulmonary function tests, the really basic ones. Now that's as much as I can actually measure with a machine. On this one, remember you have to do everything by breathing through. So what I can't measure is what I have to breathe out. So what I can't measure is what I breathe in. So some of this you have to do by mouth, all right? But notice that there is some volume under here. That there's still space. When I blow out, I'm not completely collapsing all of my alveoli. So that volume is identified as residual volume, and that's typically around 1,000 mils, 1,000 to 1,200. That could only be measured if you were to submerge me in water or pour water into my lungs after I've completely exhaled and measured the displacement of the air, and I'm not about to do that, okay? So from here to the absolute, we would have residual volume. Approximately. Again, these are variable from the individuals.
So, is the residual volume that it's the air that once we've taken as much air as we possibly can, or releasing as much air as we possibly can, there's still the residuals what's left over?
Right, so they're still going, you're not completely collapsing those alveoli.
Okay.
They're still going to have air in them. There's still going to be about 125 moles of air in your bronchi and trachea as well.
So does that mean that we can't actually breathe out everything that we breathe in, or is that, or am I not thinking of it?
Well, I mean, remember, you were adding to that. So carbon dioxide is moving into the alveoli, and oxygen is moving out. So we're losing some of what we breathe in. That's the whole purpose for breathing in. And then we're gaining CO2. So there's an exchange there. It's not molecule for molecule that we're breathing out. Okay? So again, we'll be doing this in lab. So we have the tidal volume, the inspiratory reserve, expiratory reserve, and our vital capacity is both of those. Now, there's another measurement that can be, this is the reason we're using the computers, is because it's a little tricky to measure this without some kind of a piece of tracing equipment. And this is called, it's actually a ratio of the forced expiratory volume divided by forced vital capacity. So, let me erase the board here, and you have this chart, similar diagram in your lecture notes. This is a measurement of how fast you can breathe out, all right? It's forced expiratory volume. So let's say that we breathe in a certain volume of air, and sometimes it's easier to flip this around so that we're going up. So I'm going to look at that way first. So let's say we breathe in a certain volume of air, and we'll make this 4 liters, all right? And then I'm going to breathe it out as fast as I can. So I measure that on an instrument at which this time is 1 second that I started to breathe out. This time is 2 seconds, and so on. So forced expiratory volume, or FEV, is the volume of air expired over time, or breathed out over time. So FEV1 would be this volume right here that I breathed out in 1 second. Okay? FEV2 would be that volume that I breathed out in 2 seconds. Now typically that's a little bit meaningless until we divide it by the maximum volume of air that you breathed out. Right? So if we take the forced expiratory volume 1 over forced vital capacity, and that really should be equal to your vital capacity. Okay, whether it's forced or not, your vital capacity is going to be the same. And you're going to come out with a percentage. So if I breathed out 3 liters in 1 minute, 1 second rather, and my forced vital capacity was 4, my percentage would be 75%. Okay. Typically normal is considered to be 80% or higher. You can breathe out in 1 second. Some tables will go as low as 68, but typically 80 to 84 is what's given as normal. So conditions that make it difficult to breathe out would have a lower forced expiratory volume FEV1 ratio. Okay? And typically these are COPD type conditions. So we're talking asthma, which is not necessarily a chronic COPD, emphysema, where you might have a normal vital capacity. In fact, with emphysema and chronic asthma, you actually have an increased residual volume. Because you have such difficulty getting rid of air, your residual volume tends to grow. So you have more and more air left in your lungs. So your overall pulmonary volumes are actually going to increase. With asthma, you might have a normal tidal volume, all right? But when you try to blow out, the pressure of blowing out causes those airways to get smaller, and it becomes more difficult to blow out. So you squeeze your abdominal muscles harder, and that puts even more pressure on those bronchioles and makes them even smaller. And so over time, someone who has asthma would have a test that looks like this. So they might get to a normal vital capacity, but at 1 second, they're going to have a low FEV1, all right, even though their overall volume would be normal. Now what about somebody that has pneumonia, and they have 10% of their airway, their alveoli are filled with fluid and exudate, all right, they would have, they're not blocking the airflow, they just have less overall volume available. And so their forced vital capacity would be up here instead of down here. So they may have a forced vital capacity up here, but they would be able to get, they would have a normal ratio. So their overall airflow would be down, but they would have a normal ratio. So that brings us to the next page, and the difference between obstructive and restrictive disorders. And I have struggled for years over how to, the obstructive ones I find are fine. Just think of a big boulder sitting in your trachea, and air has a difficult time getting around it. There's an obstruction, all right? So with obstructive pulmonary disorders, there is a blockage to airflow, a narrowed airway, as in asthma, okay? So there's increased residual volume, but primarily there's a decreased FEV1 ratio. So your percent is going to be low. It takes, you might get here eventually, your vital capacity would be normal, all right? You actually have an increase, so emphysema patients have these big barrel chests, they actually have an increase in total pulmonary volume, but it takes them because they're keep building up their residual volume. Restrictive has a decreased pulmonary volume. because there is some that either have tuberculosis, or maybe they've lost part of a lobe of the lung due to the tuberculosis bacilli, or they have pneumonia, or they have lung cancer. So where we have actual, with obstructive, we've gone from an airway that looks like this to an airway that looks like that. All right? That's obstructive. With restrictive, we've gone from a lung volume that looks like this to, because of fluid in the lungs, pulmonary edema, pneumonia, lung cancer, whatever, there's a whole segment of the lung we don't have available for gas exchange. So we've lost that volume. So with restrictive, you would have a decrease in vital capacity. You would have a decrease in inspiratory reserve. And I've listed some diseases on the bottom of page 48 that leads to that. Okay, just a couple more slides. So we're at the bottom of page 50. And again, if this seems a little vague, this is our lab for Thursday. Okay, these pulmonary volumes and forced expiratory volumes. Now, we'll finish up by revisiting the concepts of a conducting zone. So remember, cardiac output was equal to stroke volume times heart rate. So the volume of blood in one ventricular contraction with the number of contractions a minute. That was our cardiac output. Very similar to pulmonary ventilation. So with pulmonary ventilation, we take the volume of one breath times the respiratory rate. So the volume of a heart's contraction times heart rate is the volume of a breath times respiratory rate. So respiratory rate, which is averages about 12, times tidal volume, which averages about 500 mils, gives us an average pulmonary ventilation of 6 liters. Okay. However, not all of that air that you breathe in actually makes it to your alveoli. Because we have air that you breathe in that stays in the nose, and stays in the pharynx, and stays in the trachea, and stays in the bronchi and the bronchiole. So that is called anatomical dead space. It's approximately 150 mils. Okay? So this is the volume of pharynx to bronchioles. And it's not available for gas exchange. So in actuality, alveolar ventilation, we need to make a mathematical adjustment. We still take respiratory rate, but now we have to subtract anatomical dead space from each breath. So 12 times 500 minus 150 is equal to 12 times 350, which I've done the math, it's like 5,000. It's on the next table. 4,200. Is the amount of air that's actually reaching the gas exchange of the individual alveolar air sacs. Okay. So, would you be better off taking more rapid shallow breath or deeper but slower breath? Fewer.
Deeper.
Pardon?
Deeper.
Deeper. All right. So if in fact, I could take a shallow breath. Let's say I'm only breathing in and out 200 mils. 150 of that's not even getting to my lungs. So I'm only getting 50 mils of gas, not even oxygen, of gas to my lungs. So even if I'm breathing 40 times a minute, I'm only getting 2 liters of alveolar ventilation at 40 times a minute. Okay? Whereas I could take 5 very deep breaths. Of 1,500 mils each, subtracted by 150, and I would have over 5 liters of air getting to my lungs. Okay? So, much more, fewer number, but deeper means a greater proportion of each breath is actually getting to the individual alveoli. So that's what's shown in the chart on page 52. Alrighty, so we're done with lecture. Why don't you guys take a break in lab time. Our lab quiz today is just model structures that we talked about. So the various parts of the nose, the nares, the conchae, the parts of the pharynx, the cartilage of the larynx, the muscles of the larynx, parts of the vagus nerve, lobes of the lungs, no histology. Okay? So, lab and I could open it up, yeah. Or you can just slip it in here. Thank you.
Toss it up on a block.
Oh, thanks. Perfect.
You and I left you
There.
close.
Okay.
You got close.
Jeff's so good to you.
So when we look at, yeah, you would think after being a student of mine, hold on, getting back at me. So here's the trachea. Are you looking at a ventral or a dorsal view of the trachea? I mean, of the sheath plaque. Dorsal. Yeah. So the area of the trachea that's going to be softer tissue. Now I've got the glass tube in there, so it's hard to feel. But the trachealis muscle. Remember, the trachea is not completely surrounded by cartilage. It's C-shaped, so it's going to be open on this area. And so you can see the dorsal aspect of the lungs. The heart's going to be in the front here, so those of you that want to explore farther afterwards may do so. And then this is liver underneath. I don't see a lot of the diaphragm, but let me just grab a pair of goggles in case it explodes on me. I don't think it never has exploded. So I'm modeling good behavior here. While you're all filming this, I better model good behavior. Right? So remember the spontaneous pneumothorax in which little blebs were forming? We can create that situation on this sheet plug. And I want, if you are interested, you don't have to have gloves to do the pumping. So come up here and take an opportunity to pump the ambu bag, because that resistance that you feel is going to be what term that we looked at today?
Elasticity.
Not elasticity. Compliance.
Oh.
All right, so the resistance to the elasticity is what allows it to collapse. That's what pushed the bloody mucus into my mouth a few years ago, and the reason we developed this system. All right. So there's a little bit of leakage there. I can hear some of it coming out down the side. Looks like a turkey wrapping its little wing over here. So you'll notice that pinkish color there. All right. So go ahead. This is just. Now what are we doing here? We're pushing air into the lungs. It's going to take a greater force. This is more than 2 or 3 millimeters of pressure, because I don't have the negative pressure. I'm working against the atmospheric pressure rather than against a lower pressure. All right? So if we push really hard, you might start to see a few little blebs. So this shiny surface that you're visualizing is the visceral pleura. All right? Because otherwise our alveoli are very thin and fragile. And so that's helping to protect that with a thin amount of loose connective tissue, as well as the surface tension between the visceral pleura and the parietal pleura, which was left in the sheep. Alrighty, so if anyone wants to come up and compress those, you don't need to have gloves to do that because it doesn't have body fluids on it. You can just work on that. And so again, the compliance was the resistance to expansion, and the elasticity, the recoil, that returned it to close to original volume and thus increased intra-alveolar pressure and pushed the air out. Alrighty? So feel free. While I set up this is, remember I told you in lecture we had a head that I'd opened up the posterior pharynx, so that's what Jeff brought out for this, was that.
This is our
So on this posterior view here, it's been opened up from the posterior aspect. So this is the pharynx that's been cut. You would have up here, as high as you can reach, would be the superior constrictor. And then you can see right above here is the epiglottis. And above that would be the middle constrictor. And then right at the larynx itself would be the inferior constrictor that's been cut. And then the esophagus has been removed about this level. So we're just seeing the open trachea with its rings. All right. You can see a little bit of the posterior cricoarytenoid muscle here as well. But it's more just to give yourself, you look inside and see the false and true vocal folds. You look inside there. All right. So feel free to wear gloves and handle this, but I just wanted to give you a better feeling, no pun intended, of the pharynx from this posterior view. Okay.